Hi everyone, and welcome to this webinar where we're going to look at wound assessment, wound preparation and wound treatment. My name is Janice Bianchi and I am a tissue viability nurse advisor with Coloplast and also a lecturer at Glasgow Caledonian University where I run the leg ulcer module. With me today to manage the chat is Greg Hill. Hi, do you want to say hi, Greg? Oh, it's gone on silent.
Hello, everyone.
Hi, Greg. So any questions at all that you have, put them in the chat. Greg will manage that, and then at the end we'll go over the questions. And we also have Isha Chowdhury with us. Hi, Isha.
Hi, Janice. Hi, guys.
So, and Isha is a territory manager with Coloplast, and Isha will be given a small presentation at the end of this on the Biotin silicone range. So welcome everyone, and let's get started. So what we do know about wound management is it can be quite complex, and we were hearing this, and I as a clinician too recognise this, but what Coloplast decided to do was look at simplifying it. So they spoke to a lot of clinicians, tissue viability nurses and other nurses around the country and asked about what would make it simpler, and they came up with this three-step approach, which is step 1, assess, step 2, prepare the wound, and step 3, treat. And that's what we're going to look at today in the context of the wounds that you might see. And why are we assessing wounds? Well, of course, we're assessing wounds for all of these things. So to identify the cause of the skin breakdown, to identify if there are any associated factors, is this because of peripheral vascular disease? Is it a pressure ulcer? We then look to correct or treat any underlying causes that we can treat and identify appropriate management options for that individual. We would look at controlling the symptoms that that person has and trying to prevent further wound deterioration. And then, really importantly, identifying the patient's expectations, because for us as nurses, we want to heal wounds. And that's perfectly understandable. But for that individual, it might be that the smell is the thing that's really bothering them, or the amount of exudate, they're embarrassed by that. So what is important to that person? And also thinking about the psychosocial support we need to give to that person to promote them to be as independent as possible. And how often do we assess wounds? That depends, doesn't it? It depends on that person with a wound. It depends on the condition of the wound and where they are. But as a minimum, we would be doing a formal assessment every 2 weeks in the acute setting and every 4 weeks in the primary care setting or community setting. But obviously, every time you remove a dressing, you're doing an informal assessment of that wound. Because if we don't do a detailed assessment, this is the sort of thing that can happen, and you can see the deterioration from the top picture to the bottom picture in this wound, primarily because of inadequate wound assessment. If we don't assess wounds correctly, we can't identify the factors which are delaying healing. We might make the wrong management choice. People can then develop infections. Healing can be delayed and the costs go up significantly because you've got a longer time to heal that wound. And the cost, remember, for that individual, both psychologically and financially perhaps. So a careful assessment is really important to make sure that we've got that person on an appropriate treatment plan. And we've got loads of challenges, and you can see here just a big selection of challenges, and I'll not go into all of them, but if we think about patient factors, things like other illnesses that person might have, are they in pain? Do they have mental health issues? Are they depressed? Are they unable to care for themselves? These are all challenges for us when we're doing our wound assessment. And then if you think about the wound itself, the size of the wound, a bigger wound will probably take longer to heal. How long that wound has been there, so chronicity will indicate that it's going to, again, it'll take longer to heal. Is there a good blood supply to the area? Here we're thinking about lower legs and foot. bacterial burden, oedema, exudate, etc. So all these wound factors make assessment challenging. And then educational factors. There is ritualistic practice and traditional practice. What we learned sometimes many, many years ago, we still, if we haven't updated our practice, then that's what we'll follow. And that can be for a number of reasons, that actually there hasn't been training available, or there's not enough research in the area that we're looking at. So lots of reasons why educational factors will come into assessing wounds and making it challenging. And then organisational factors. We know that the NHS is in a state of flux, shall I say, at the moment. There's a lot of vacancies, so we don't have the staffing, we don't have enough staff. We may have an inappropriate skill mix. We might have lack of clinical guidance and guidelines. So lots of issues here which make wound assessment challenging, and hopefully what we're talking about today will help to simplify that in some ways. And this is this simplified method of wound assessment. So looking at the triangle of wound assessment, where we think about the patient themselves, their comorbidities and etc., their mobility, their socio-economic factors, and then looking at the wound and looking at the wound bed, the wound edge, and the peri-wound skin to tell us what's happening with that wound and how we can move things forward. So if we're thinking about that holistic assessment, these are the key things that we are doing here. We're taking a history to identify factors which could delay the healing process, to understand our patient's concerns and build a rapport with that person, because you're probably going to be seeing them for a considerable period of time while they have this wound. We would consider medication, so their current medication, or any that have changed or been discontinued, the dosage of their medication, the frequency, is it working for them? Is it efficacious? Are there side effects that they're finding uncomfortable? And are they able to comply with their medication? So all of these things are part of our listening in this triangle of wound assessment. The age of the person, we think about, because at the extremes of age, wound healing can be delayed. Body weight, mobility. Is that person anxious or tired or confused, or are they sweaty? Are they in pain? Are they breathless? We're looking for all of these signs. We would also do our clinical observations and ask about dressings that they've previously had and how successful they have been in the past. And it is a top-to-toe skin assessment, so we're looking for this to make sure we have the correct treatment plan. We're looking for dryness in the skin or dehydration, or is the skin moist? Is there a lot of maceration, particularly around about the wound? Exudate? Is the person incontinent? Do they have lymphedema? All of these things when you're looking at that top-to-toe assessment. If this is a wound on the leg or the foot, do they have good foot pulses, or are their pulses absent? What about pain? Is it a new pain, so nociceptive pain, or is it a chronic pain, a neuropathic pain? And then temperature, particularly round about the wound area. Is it inflammation or infection? Is it on a pressure point? Is there non-blanching erythema? Is there ischemia? Or is there deep tissue injury? All of these things we need to consider. And then, is there skin sensitivity, numbness, burning, or tingling, particularly in the feet? And here we're thinking about peripheral neuropathy. And then our sense of smell. And we know that odour is undervalued during skin assessment because we're used to smelling unpleasant smells as nurses. But really, we need to take heed of this. And is the odour because of any of these things? So is it just that person's not managing with their personal hygiene? Is it because of incontinence, or is it because of the wound? Is the wound producing exudate? Is it sloughy or necrotic? Is it perhaps a malignant wound? And what effect is that having on the person who is living with this smell 24 hours a day? And that can be significant. Then looking now at the wound itself. And these are the different tissue types that you might see in a wound, and we'll just look at these individually. So necrotic tissue, first of all. Necrotic tissue can be soft and wet, or it can be hard and dry, and it's usually black or sort of dark brown in appearance. And it's dead tissue, and it contains dead cells and cellular debris which collects in the surface of the wound. But if there's a poor perfusion there, necrotic tissue can spread quite quickly. And ideally, necrotic tissue should be removed from the wound bed, and it needs to be carefully removed. So that tends to be in the hands of a specialist, such as the tissue viability nurse or for a foot podiatry, or some surgeons too will do this. Fluffy tissue is another thing we typically see in a wound, and it can vary in colour from yellow, like you see here, to a sort of grey-green colour. And it consists of fibrin, pus, proteinaceous materials and dead cells. So neutrophils, white blood cells, as they die, they lie on the top of the wound, and it's a sort of creamy white colour you often see with dead neutrophils. Sloppy tissue tends to collect in deeper areas of the wound, and it can increase the bacterial burden in the wound, and it can lead to more infection. So sloppy tissue is detrimental to healing, and we should be carefully removing it from the wound. And then granulation. Generally speaking, when we see this, like this wound here, we're delighted. Things are going well. So granulation tissue is red or pink, and it's new connective tissue. And if you looked under a microscope, it's little blood vessels which have grown into the wound. And it's the sort of later stages of the wound healing process. Normally grows from the wound base up, but if granulation tissue is friable and bleeds easily, it can be an indication that there's local infection, especially if the person's complaining of pain. So bleeding and pain, think, although this looks nice, like nice granulation tissue, there could be infection there. And then the final phase of wound healing epithelialization, is where the new skin epithelium forms over the top, and that's what you're seeing here. So it grows from the wound edges, so you can see in this picture the purplish edge of the wound, but also the little islands of epithelium within the wound, and they're grown from the hair follicles or the sebaceous glands. And this is great. When we get to this stage, we know this wound is well on the way to healing. What we need to do here is promote a moist wound environment. So keep the wound moist, and most of the modern dressings are based on this moist wound principle, because epithelialization happens more quickly on a wet wound bed than a dry wound bed. Then we have to think about exudate. So exudate will be in different volumes, consistency and colour. So the volume of exudate, it can be a completely dry wound, low levels of exudate or medium to high levels. The consistency can be very thin and watery, or it can be quite a thick exudate, and that's what you're seeing here in the picture that you see. And the colour can be clear or cloudy or purulent or pinky red. So, you know, then there's blood involved as well. And the exudate here there's a considerable amount of exudate in this wound, as you can see, and it's probably high level, quite thick and quite purulent. But we know that as exudate levels reduce, this is an indication that the wound is well on its way to healing. So a reduction in exudate is usually a really good sign. And then infection, think about infection, either local infection, which is the top picture you're seeing here, or a spreading infection. So with local infection, the person will be reporting more pain. There will be redness, erythema, oedema. It will feel warm compared to the skin next to it. So you just hold your hand above that and you'll feel warmth. There's an increased level of exudate often, and the wound gets stuck, it's delayed, the healing is delayed, or there's granulation tissue there, but it's quite friable, so it bleeds really easily. Malodour is another typical thing, so a new odour will indicate infection if there are other signs of infection, and pocketing in the wound. And then a spreading infection, which you're seeing in this second picture, which is quite a nasty spreading infection, there's increased redness or erythema. The person will be unwell. They'll feel unwell. They'll have a pyrexia. There will be perhaps abscess or pus. There'll be a lot of pain. And well, what we're seeing here is a cellulitis, and the wound can break down quite rapidly when there is a spreading infection. So wound bed assessment, these are the things that we're looking for. We're looking for the type of tissue present and what tissue is predominant. And you usually, in your wound assessment chart, it'll give you percentages. So you put a percentage of each of the types of tissue that you're seeing in the wound. How much exudate, what colour and how thick it is. Are there any signs of infection? How deep is the wound? Are there structures which are visible? So you can see here that you're seeing, this is either tendon or fascia, but it could be muscle, fat, joint capsule or bone. And if you see that, you need to report on that too. And then we look at the wound edge for signs of what we need to do and how this wound is progressing. And these are the different things we can see in a wound edge, and we'll look at all of these different things. So maceration is the first thing you might see in a wound. It's a waterlogged edge round about the wound. So the little epithelial cells are all completely waterlogged and now quite unstable. It's indicating to you, when you're looking at this, that you need to think about a dressing which perhaps has more absorption powers, because this is a wound which is producing a significant amount of exudate. And if we don't get on top of this, the wound can get bigger. It can lead to fungal infections. It can lead to bacterial infections. And then the opposite of that, and what you're seeing here in this wound, is complete dehydration. So the wound is dehydrated, it's producing no exudate at all, and the epithelial cells are stuck. They can't move across this dry wound. So here we want to hydrate the wound. We want to add some fluid or create moisture to encourage the wound to become more moist and then trigger moist wound healing. And then undermining is another thing that we can see with the edge of a wound. So you can see here that there is a shadow where the arrow is pointing to indicate that that area is undermined. This tends to happen in chronic wounds, often quite large wounds, and the patient very often has other comorbidities. So these are complicated wounds and difficult to heal. And then rolled edges can be there for a number of reasons. Again, it tends to be larger, deeper wounds. And because the wound edge is rolled back on itself, the epithelial cells, again, are stuck. They can't complete the wound healing process. This is often a case for surgical interventions. So again, speaking to your tissue viability nurse, but we need to be aware as well that a rolled edge can be caused by malignancy. So we need to be careful and consider that too, and make the appropriate assessment and referral to specialists. So just to summarise, when we're thinking about wound edges, we need to think, is there maceration present anywhere? Or is there dehydration? And what we're going to do about that. Is there any undermining? And if so, to what extent and where is the undermining? Or are there any signs that the edges are rolled and that the person needs further investigation? So all of these considerations when we're thinking about the wound edge. And then finally in this part, the peri-wound skin. And again, there are a number of things which can happen to the peri-wound skin, which we have to take action with. So maceration we've talked about as far as the wound edge is concerned, but you can see in this picture, because of the level of exudate, the whole heel has become macerated. So you've got potential here for a lot of skin breakdown. The wound exudate is quite an irritant to the skin. It can cause inflammation and it can cause further breakdown. So we need to make sure that we're using a dressing which is going to take that exudate away from the wound to avoid this kind of maceration. Excoriation is caused by a number of things. It's caused by trauma, but that can be scratching, it can be abrasion, it can be a drug reaction, it can be irritants. But the key thing here is emollients, because this is going to be uncomfortable, it's going to be itchy. And emollients will reduce the inflammation, give the barrier, help to replace the barrier function in the skin and reduce the itch. So that helps to interrupt the itch, scratch, itch cycle. And then dryness, similar to excoriation. And you can see in the diagram in the top picture what the keratinocytes look like when the skin's really dry. And you know, you've seen this skin that's really, really dry and flaky, very often in an elderly person, very often in the lower leg. The skin, when it's dry, itches, which means that the person will scratch and they'll damage that protective layer of their skin, the acid mantle, as we call it. So what we need to do is donate fluid to that area, and that's emollients again, using emollients to prevent scratching, to improve the quality of the skin and allow healing to take place and minimise the risk of another wound occurring through scratching. And then hyperkeratosis is another condition that you see in the peri-wound skin. It's often seen on the lower limbs, particularly in patients with leg ulcers, but also it can be seen in the hands, the heels, the soles of the feet, and in diabetics, particularly on the feet. And again, this can impede healing, and we should try to get rid of this hyperkeratosis if we possibly can. And then callus, which is a thickened layer of dry avascular skin at the wound edge, which is usually seen in people with diabetic foot. It's hardened skin where there's been pressure and friction, and it needs to be removed. But fortunately, this is a job for the podiatrist, so they would deal with this kind of callus. And then eczema or dermatitis, which is inflammation of the skin, again, very commonly seen in people with venous disease. It's itchy, red, often there are little vesicles, that's like tiny little blisters. There's weeping and crusting because people scratch because it's itchy. We're not actually totally clear on why venous dermatitis or venous varicose eczema occurs, but it's thought to be an interplay between the immune system and the skin, and it is associated with venous leg ulcers and venous insufficiency. So if we're thinking about this, these are the questions that we need to ask when we're doing our assessment. How long has the wound been present? What is the nature of the wound's location? The size, depth and shape of the wound? Is there tracking, undermining or tunnelling? And what about the surrounding skin? How does it look? And then thinking about the type of tissue in the wound bed, the amount of exudate and the consistency of the exudate. Does the patient experience any pain in the wound? And what's the condition of the wound edges? And using this information, it helps you to confirm what this wound is and then think about what we're going to do as far as treatment's concerned. These are some of the investigations that you might do depending on that wound and that individual. So a full blood screening, wound swab if you're seeing clinical signs of infection, an ankle brachial pressure index with people with leg ulcers, and pressure perception, so monofilaments for diabetic foot ulcers. So these are all additional tests to help us with our diagnosis of what's happening and what the cause of that wound is. Documentation, remember, key things. So relevant, factual, consistent and accurate documentation is what we're all aiming for. Ideally, write it as soon as possible after the event. Write it clearly, have a management plan. the decisions which are made, the care that's going to be delivered, and the information that you've shared with that patient or their carer or their relative. And then date and sign accurately for every entry. And confirm this with the patient. So you're confirming your action plan and what you're going to do, what investigations they may be having to have, what other members of the team are you referring them to? Are you referring them to dermatology, tissue viability, vascular, details of specific treatments, plans for shared or self-care if that's appropriate, and plans for discharge. And the clinicians should involve the person, check that they understand the action plan and address any questions and concerns that they may have. And this can take a wee bit of time, but doing it right at the start like this means that that person is going away with the correct information and doesn't leave you and be thinking, oh, I can't quite remember what I'm supposed to do. So written information is also really, really useful too. Supported shared or self-care in wound care is something that we're seeing more and more of. And when it's right for the right person, it works really well. So for some people with leg ulcers, for example, they are seeing the nurse every second treatment. So they're managing the wound themselves and seeing the nurse, say, once a week, once a fortnight or longer. And if that person is working or busy with, you know, grandchildren and hobbies, it can be a really, really good thing. But what we have to think about is we should encourage people to share their care if they're willing and able to do so. And we have to make that assessment to make sure that they are. And that could be the person, that could be their carer, that could be a family member. But what we have to do if this is happening is to provide simple wound care management plans. We need to instruct on how to wash hands and how to change dressings, and educate the person on monitoring for signs where there's a problem arising and how they should get in contact with you if any problems do arise. But it's something that we all need to consider more and more, and it can work very, very effectively. We're now going to think about wound preparation. So we've done our very detailed assessment. We're looking at the wound now to see what we need to do with the wound to encourage that wound healing process. And this is step 2 in the 3-step approach. And these are the challenges that you're going to be faced with. So the wound might have an excessive amount of fibrin or slough. It might have necrotic tissue, and it might have a high bacterial burden. And it also might be, as we've looked at before, hyperkeratosis that is the challenge. So let's think about what we do. And things have changed. And when I was taught way back, a long time ago in wound management, I was taught that you were very careful not to disturb the wound bed. And you can see from the third quote here, I was always taught to only cleanse the wound edge, never touch the actual wound bed or the peri-wound skin. And the quote at the bottom, I don't want to cause trauma by disturbing the wound. So I can understand why people are reluctant to use wound preparation, but things have moved on, and we'll have a look at why that is. We know now with the increased knowledge in wound care that slough and non-viable tissue and biofilms, which we'll go into in a minute or two, can delay the wound healing process because they can increase the risk of infection, inhibit the development of healthy tissue, and they limit your ability to assess the wound. So why do we need to remove devitalised tissue? Devitalised tissue potentially will increase the healing time, increase the risk of infection, keeps the wound in that inflammatory process, and the cytokines which are involved in inflammation, there will be higher levels of them. So the wound will be stuck in the inflammatory response very often if we have this type of wound bed that you're seeing here. So by cleansing and wound debridement, we can remove the barriers to healing, such as slough, non-viable tissue and biofilms. And it's important for all of those reasons. We know that devitalised tissue slows down the healing process, that we might have a biofilm there, which means that if you're going to use an active ingredient, so one of the antimicrobial type dressings, if there's a biofilm present in the wound, it can inhibit its effect. So lots of reasons why we need to think about debriding and preparing the wound bed, the wound edge and the peri-wound skin. And this was a study which was done looking at diabetic feet, and it was quite a simple study, but they looked at two groups of patients, and in one group, debridement was carried out once a week. And in the second group, debridement was carried out once a fortnight. And they looked at the median healing time for these patients with diabetic foot ulcers. And as you can see here, in the people who had more frequent debridement, that's once a week, the median healing time was 21 days compared to 76 days when it was every fortnight. So that's a huge difference. So we know that regular debridement of a wound will speed up healing. And there are lots of different debridement tools available. Surgical and sharp debridement are usually done by a tissue viability nurse or a medic or a podiatrist. But all of the other forms of debridement we can use and would use regularly. I'm going to talk about really the one that we're focusing on here is mechanical debridement. It's gaining popularity, and we don't need specific training or knowledge or skills to carry out mechanical debridement. And this is just one example of it. And how often do we need to prepare a wound? That will depend on how well the wound's doing. Is it going really well, or is it really stuck? So it depends on your assessment, your clinical judgment, what your treatment goals are, and that person's pain level. And that's obviously something we have to consider. And you can see in this wound here, there is a lot of fluffy tissue, probably a bacterial burden there. So yes, this is a wound where, if it's appropriate, debridement would work really well for this wound. We should be cautious, of course, and there are patients that we shouldn't, or we have to be cautious and make the decision depending on that individual. So people who have a lower limb wound and are a known diabetic, it might be better to speak to the podiatrist. If the patient has a poor arterial flow to that limb, then we have to be cautious. Or if the person's on medications or which are immunosuppressive, or they have a condition which means that they're immunosuppressed, then we have to be cautious about wound preparation in these individuals too. I mentioned biofilms, and if you're not aware of what biofilms are, they are communities of bacteria, fungi and viruses within wounds, which are covered in a protective coating called a biofilm. It's a polysaccharide matrix or a sugary coating. And if you can imagine a wound with these little balloons attached, and it could be hundreds or thousands of them all within the wound, protecting the bioburden within the wound. So biofilms exist in wounds. Up to 80% of non-healing wounds are estimated to contain biofilms, but they exist everywhere in life. So in the U-bend of your sink, if you see a boat in a harbour kind of bobbing up and down, you'll see a scum, that's a biofilm, but also on our teeth. And we remove the biofilm from our teeth by brushing our teeth. So, and it continually builds up, and that's why we have to think in the same way with wounds. We're not going to brush wounds, but mechanical debridement is a good alternative for wounds. And this is an international best practice statement on biofilms, which again reiterates this, that wound preparation, cleansing and debriding to reduce the number of microorganisms and by disturbing or removing some of the biofilm is the recommendation from the international best practice guidance. Use a barrier dressing after that, and if needed, use an active ingredient in the dressing, so an antimicrobial dressing if there's infection there. So you've assessed the wound, you've prepared the wound, and now you think about what are we going to do next with the wound? What kind of treatments are we going to use? And this is the third step in our approach to simplifying wound management. And we know that wounds heal by primary or secondary intention. And here we're talking about wounds which heal by secondary intention. So secondary intention is where the wound heals from the base up. Chronic wounds generally heal in this way, or wounds which we can't heal by primary intention. And there will be very often a prolonged inflammatory stage, and this might be due to biofilm or infection. So we need to monitor them closely, and that has to be staff who are trained to do so. And these are the things that we're looking for in the treatment objectives. We want to prevent exudate from pooling in the wound. We want to remove all of that chronic wound exudate from the wound bed. We want to protect the peri-wound skin. We want from exudate which will cause maceration or excoriation. We need to think about the depth of the wound, how deep is it, and do we need to make sure that the wound dressing is getting right down to the base of the wound, and we need to think about infection. So identifying the treatment of any and treating any of these underlying causes is integral to what we're going to do with wound healing and creating that optimum environment for healing. And these are the dressings which you will have available to you. Now, we don't have time to go into every single dressing here today, but your wound formulary will have all of these categories. So it is worth having an awareness of all of these categories and what the different dressing types do, so that you know you've got all that information when you're choosing the right dressing for your patient. And I just wanted to finish with a couple of case studies before I hand over to Isha, because this kind of brings it to life. It's all very well talking about the theory of all of this, but in practice, the people that you're dealing with and the challenges that you have are always a lot more interesting. So let's have a look at this first case study. And this was a 90-year-old man who had leg ulcers, and he'd had leg ulcers for 10 years. It was mixed etiology, so arterial and venous elements to it. His ABPI was out with the normal parameters, so they couldn't use full compression. And he had been, in that 10 years, he'd lost his confidence about travelling and getting out and about in the world. They assessed the wound using the triangle of wound assessment, and they recognised the management goals were to remove non-viable tissue, manage the exudate, manage the bacterial burden, protect the new granulation tissue, and protect the skin. And for this, they used All-Prep pad, and they treated the wound with biotin AG non-adhesive. So more than 10 years with a wound, he found wound preparation painful, but with All-Prep pad, he was able to tolerate it and saw that there was visible, significant progress. He was able to tolerate 10 millimeters of mercury at this point, so a little bit of compression, a liner, after day 3 actually of treatment, and he hadn't been able to do this before because of the pain and exudate. And after managing the infection and the exudate levels with biotin AG non-adhesive, Mr. H was able to help in shared care by using biotin silicone and hosiery. And his wound healed after 54 days. And that was after like 10 years of treatment previously. So just going back to the start again and thinking about assess, prepare, treat, and thinking about what your goals are, you can see the really positive result for this person. And then a final case study for you. This is a 39-year-old man, young man with spina bifida, but very independent, he had a busy social life and work life, didn't take any medication, but he'd had this wound for 15 years on his ischial tuberosity. And again, they went back to the start again and thought, okay, What we need to do is remove non-viable tissue, manage the exudate, manage the bacterial burden and protect the skin. And again here they used Oprep pad and biotin alginate AG this time, and a biotin dressing on top. The pressure also responded well to management with Oprep pad and the biotin alginate AG, and that managed the bacterial burden really well. It allowed the wound to progress to healing. Not completely healed, as you can see, but can see the difference in 16 days. Jamie was much happier and found that the wound was less painful than it previously had been, and he had less leakage, less maceration, so in turn it improved his quality of life. So a really positive outcome in these two case studies, which is what we all want to see, isn't it? So thank you very much for listening to me. And I'm going to hand back to Greg now, just to ask if there were any questions, Greg.
No, there weren't anything that had come through throughout the call.
It was a whistle-stop tour, folks, but I'm going to hand over now. I'll stop sharing. Sorry, I'll stop sharing and hand over to Isha. And thank you for listening to me. And Isha, I'll let you carry on. Thank you.
Thanks, Janice. That was great. Quick introduction to myself. So my name is Isha Chowdhury. I am here from Coloplast, as Janice mentioned. My role with Coloplast as a territory manager is to provide product support and training. So today what we'll be doing is we'll be covering Biotin silicone, which is our silicone foam dressing that is on most formularies across Scotland. So what I'm going to do is share my screen. Janice, if you could let me know once you can see my screen.
Yeah, I can't. No, it's not in presenter mode yet, but yes, I can see it.
Perfect. There we go. Can you see that okay?
Yep, so it's just your front page. It's not the actual presentation.
Let me have a look.
Person running along a beach. It looks lovely.
Oh, right. Let me see. Still coming up as a front page?
Yes, it is.
Okay, right. So I think we're having some technical issues with this. So what I'm going to do is I'm going to share my screen as is. So hopefully you can see this and we can kind of run through it as is. So as I said, my name is Isha Chowdhury. I'm here from Coloplast as a territory manager. I cover the west of Scotland, and my colleague Murray Johnson covers the east of Scotland. So hopefully I've kind of met most of you if you're from west of Scotland. If not, you'll probably have came in contact with my colleague Murray. What we're going to be doing today is covering Biotin silicone. Throughout the presentation that Janice presented, she kind of alluded towards some of the most common issues and challenges that you guys are dealing with on a day-to-day basis. So we'll look at what some of those challenges what are in terms of the challenges that are preventing wound healing at the moment for you guys. And then we'll look at how Biotin silicone helps to deal with some of those challenges and provide the kind of the optimal healing solution for your wounds. So one of the kind of the most common challenges that we hear about, and what Janice kind of alluded to, was towards leaking and maceration. So again, this is just when exudate isn't managed properly by the dressing, and it leaks up onto the peri-wound skin, causing maceration. I'm sure looking at this image, you can relate to some of your patients that you may already have on your caseload at the moment. One of the other challenges, again, that we often hear about is infection. Again, this is just when exudate isn't managed properly through the dressing, and it's left to kind of pull within the actual wound site, and it ends up leading to bacteria buildup and infection. So again, preventing the healing for the patient, the patient needing to stay on your caseload for a lot longer, and again, other modes of medication kind of needing to be taken, such as antimicrobial, as well as your normal treatment plan. So where does biotin silicone sit, and how does it help deal with some of those kind of common issues that you're currently dealing with? So biotin silicone has three main features which help to kind of deal with your wound and provide that optimal environment. So first and foremost, biotin silicone absorbs exudate vertically. So what that basically means is that once a dressing is applied onto the dressing, onto the wound bed, and it comes in contact with exudate, it will absorb the exudate vertically rather than spreading across the wound bed kind of laterally. So what that basically means is preventing the exudate from coming into contact with the peri-wound skin and the surrounding skin, and preventing the risk of maceration and leakage. Biotin silicone also conforms down to the wound bed. So any wound that has depth of up to 2 centimeters and doesn't have any undermining or tunneling, you're able to use biotin silicone on its own without any additional dressing. So it's basically a 2-in-1 dressing where you don't need to use a filler for wounds that are up to 2 centimeters in depth, providing there's no undermining or tunneling. So again, it's conforming down to the wound bed, absorbing the exudate, and preventing any sort of pooling and leaking occurring at the wound site. Lastly, biotin silicone helps to retain and absorb exudate within the dressing. So it not only absorbs the exudate within the dressing, but also retains it within the actual dressing as well. Again, preventing the risk of infection and bacteria occurring at the wound site. And what we're going to do is we're going to have a look at a quick video which explains a bit more behind the technology of biotin silicone and how it basically works. But before we do that, I'm going to quickly share a demo of biotin silicone on this demo board here. So I've got biotin silicone, and this is a 12.5 by 12.5 dressing, and I've got a demo board along here. I'm going to apply 6 to 7 mils of exudate onto this wound model, like so. And then I'm going to apply biotin silicone on top of it. One of the things that I absolutely love about biotin silicone is how the dressing itself is applied. So with most conventional dressing, you have 2 tabs that you remove and then apply it onto the patient's skin, and it often ends up sticking to the patient, your glove and everything else in between rather than the site. Whereas with biotin silicone, you take the center tab off first and then apply the dressing onto the site. So at no point are you coming in contact with the silicone itself, and it gives you a nice creaseless application of the dressing. So I'm going to leave that on for a couple of minutes, and in that time we'll look at the video and we'll come back to it, and just to show how absorption and retention works with biotin silicone. I'm going to share my screen again, and we'll share the video. Bear with me 2 seconds. Janice, if you could confirm you can see my screen.
Yep, we can.
Perfect.
Biotin silicone with 3D fit technology conforms to the wound bed to prevent gaps and exudate pooling. It absorbs the wound exudate and stops pooling before it starts. 3D fit is a highly absorbing foam technology with strategically placed microcapillaries. Once it comes in contact with wound exudate, the microcapillaries go into action, absorbing exudate vertically. As the 3D fit technology absorbs the wound exudate, biotin silicone conforms to the wound bed. The exudate is locked away and retained even under compression, reducing risk of leakage and maceration of the wound edges and peri-wound skin. As a result, the exudate is effectively managed. Biotin silicone, a perfect fit every time.
Okay, so as you saw on the video there, it just shows how the biotin silicone works in terms of absorbing exudate, retaining the exudate, and conforming down to the wound bed. We've also got some really good study which highlight the effectiveness of biotin silicone in comparison to other dressings, conventional dressings that are available on the market at the moment. So this here is a clinical study which was done by the NHS clinical evaluation team. So it was done by the NHS clinical team, and they looked at top 10 dressings that were available across the market, and they looked at how effectively each of those dressings manage exudate. And the study found that biotin silicone came out on top of the market-leading products as the strongest silicone foam at absorbing exudate as well as retaining it. What I'll do is I'll share the study with you guys following the call, so you guys have got that and you can kind of look at it in a bit more depth. The second study that I wanted to share with you was a case series that was done across 3 sites, one in Dublin, one in England, and one of them was a bit local to home, so NHS Lothian, which looked at around 137 patients. And what they found was that they were able to switch patients, 49% of their patients, from multiple dressing to a singular dressing, again, just reducing the needs of primary and secondary dressing and just using biotin silicone on its own. And the results showed that they were able to reduce unit cost by 49%. So they were saving the amount of products they were needing to use. They were saving on the time that they were needing to change the dressing, and they were also able to allow their patient to do more supported self-care as well. So offered them quite a few range of benefits. In terms of the shapes and sizes that are available within the biotin silicone range, you've got a good variation available. So the top 5 sizes that you've got here, 7.5 by 7.5 to 17.5 by 17.5, these are your square dressings. Then you've got a few more shapes available. So the next one is you've got multi-shape available, you've got the heel, and then you've got 2 sacral sizes available as well. And then lastly, you've got 2 surgical size dressing, which are your 10 by 20 and 10 by 30. So that's the full range of biotin silicone. I think the demo is just needing just a couple of minutes longer to really set in place. So what we'll do in the meantime is I've got, I'm going to share the screen with everyone. So it's basically a QR code. Everyone should be able to scan it using their phone. It'll take you on to a Microsoft form, which basically asks you a couple of questions just regarding the training that Janice has provided for you guys today. So if you could scan the QR code and fill out that information, that would be immensely appreciated. I'll also put the link in the chat for you as well. And you can use the link to fill out the questions as well if you're unable to scan the QR code. Janice, I'm going to pass it back to you just to take any questions at the moment, and then we can come back to the demo.
Thanks, Isha. Well, no, there are no other questions. I guess people are either totally confused or very happy with everything. Hopefully the latter. But no, there are no other questions, Isha. So are you ready with the final part of your demo?
Yes, that should take me 2 seconds. I'm just sharing the evaluation form onto the chat. Yeah, so this seems like it's pretty much done. So what you can see with the demo there is the exudate has been absorbed by the dressing and it's been absorbed vertically. And then when I take the dressing off, what you'll notice is that there is minimal amount of exudate that's actually left within the demo board. and all of it has been absorbed by the dressing like so. And if I turn it to the side, you'll be able to see that the dressing is actually conformed to the shape of the wound model. So you can see that there's an indentation that's taken place, and all the exudate is retained within that site. So it hasn't spread laterally, it's retained and absorbed just within the actual wound bed. Okay, so I'll share all the information that we've discussed today just following this call. And if you guys have any questions or require further training, please reach out to me and I'd be more than happy to help out.